Welcome back to the Pro PA podcast, where we break down high-yield topics to help PA students and practicing PAs level up their clinical knowledge. I'm your host, Prof. G, and this is another episode in our MSK101 series covering musculoskeletal topics straight from the PANCE blueprint. In this episode, we'll cover two key metabolic bone diseases, osteoporosis and osteomalacia. These are common conditions, and understanding their key differences is crucial for both PANCE and real-world clinical practice. Let's dive in. Did you know that nearly half of all women over 50 will experience an osteoporosis-related fracture in their lifetime? And despite this, many remain undiagnosed and untreated until after a fracture occurs. Meanwhile, osteomalacia, though less common in the US, is frequently misdiagnosed, especially in patients with chronic vitamin D deficiency. These are not just textbook topics. They're real-life conditions you'll see in primary care and hospital settings. So first, let's start off with the kinder patho. What is osteoporosis and osteomalacia? Well, osteoporosis is a condition of low bone mass and microarchitectural deterioration that leads to bone fragility and increased fracture risk. Osteomalacia is a defect in bone mineralization, most commonly due to vitamin D deficiency in adults, leading to soft bones. A helpful way to remember the distinction is that osteoporosis equals porous bones due to the loss of bone mass, whereas osteomalacia is soft bones due to poor mineralization. As a side note, we'll be covering rickets, the pediatric counterpart to osteomalacia, in a separate dedicated episode, so stay tuned for that. All right, so what is the clinical presentation? Well, first let's look at osteoporosis. In osteoporosis, we often have asymptomatic patients until a fracture occurs. Now, fracture locations are most often found in the vertebrae, so we see vertebral compression fractures. We can also see hip fractures and distal radius fractures, or Colles fractures. These may also present with height loss or kyphosis in elderly patients. Kyphosis is the forward bending of the T and C spine in the upper thorax. Osteomalacia, on the other hand, typically causes diffuse bone pain, muscle weakness, and a waddling gait. And patients may report difficulty in rising from chairs or climbing stairs. So how do we diagnose these patients and do a workup? Well, in osteoporosis, a DEXA scan is the gold standard. And we're looking for a T-score less than or equal to negative 2.5, and this will confirm our diagnosis. Labs, on the other hand, are usually normal in osteoporosis. We're looking for things like calcium, phosphate, and PTH. Now, in osteomalacia, we see a decreased vitamin D levels, decreased calcium levels, and decreased phosphate levels, whereas we see increased PTH and increased alkaline phosphatase. X-rays may show looser zones or pseudofractures. All right, so how do we treat osteoporosis? Well, the first-line treatment is going to be bisphosphonates. And these are medications like alendronate, also known as Fosamax. We're also going to supplement calcium and vitamin D for osteoporosis, as well as recommend lifestyle modifications like including weight-bearing exercise into their routine. We're also going to encourage smoking cessation and give them recommendations on fall prevention. We can also consider medications like denosumab, raloxifene, or teriparatide in certain populations. As far as osteomalacia, vitamin D supplementation is going to be key. We want to address dietary deficiencies and underlying causes, as well as calcium supplementation as needed. So bookmed versus streetmed. The bookmed is going to tell us that everyone over 65 gets a DEXA scan. Bisphosphonates are effective and well tolerated, and osteomalacia is rare and straightforward to diagnose. The street med, however, is that many patients don't tolerate oral bisphosphonates due to GI upset or esophagitis. And osteomalacia may present subtly in immigrant populations or in those with limited sun exposure. Vitamin D deficiency is more common than you think it is. Now, some clinical pearls. Screen women greater than or equal to 65 years old with a DEXA scan. Osteoporosis equals normal labs and fractures without trauma. Osteomalacia equals abnormal labs with bone pain and weakness. Morning sun and fortified milk won't always cut it. Check those vitamin D levels. As a side note, my vitamin D levels are always super low, and that's because I spend a lot of time in front of my computer doing things to put out these podcasts and teaching. So, without getting a lot of vitamin D from my sun, my vitamin D levels are very, very low, and I have to supplement them. As you might notice yourself as a PA student or a PA working inside all the time. All right, so next up are some PANCE style questions to test our knowledge. Question 1: a 67-year-old woman is found to have a T score of negative 2.7. Her calcium and vitamin D levels are within normal limits. What is the most appropriate initial treatment? Is it A, teriparatide, B, denosumab, C, alendronate, or D, raloxifene? If you said C, alendronate, you are correct. Remember, bisphosphonates are the first-line treatment for postmenopausal osteoporosis. Question 2. A 45-year-old man with a history of malabsorption presents with diffuse bone pain and muscle weakness. His labs show low calcium, low phosphate, and elevated alkaline phosphatase. What's the most likely diagnosis? Is it A, Paget disease, B, osteoporosis, C, osteomalacia, or D, hyperparathyroidism? I'll give you a few seconds. If you said C, osteomalacia, you are correct. Remember, classic lab findings and clinical features point to vitamin D deficiency affecting mineralization. All right, well, that wraps up our metabolic bone disease overview. Remember, osteoporosis is about bone loss, osteomalacia is about defective bone mineralization. Two different problems, two different management plans. Make sure to tune in next time because we'll be covering rickets in kids as its own standalone topic. It's rare in the US, but definitely worth knowing for the boards. And remember, this has been the ProPA podcast, where future pros in medicine are made. I'll see you next time.